can see there is 1, 2, and 3, and 3 terminations, 2 common iliacs and median side. The 3 anteriors which we concerned about, celiac, superior mesenteric, and inferior mesenteric artery. The first one is the celiac trunk. Why they call it a trunk? Like the trunk of the tree, it's very large. The artery is very large, we call it trunk. From this trunk there will be many or several branches. Okay? When the vein is large, we call it sinus. Okay? A large vein is a sinus. Celiac is a Greek word which means from coeliac, which means the belly, because it's the largest, okay, gastrointestinal branch in the belly or in the abdomen. Okay? Celiac trunk actually is very wide, as I told you, large, but however it's short. Okay? It's around 1.2 to 1.3 centimeters. Okay? So this artery, which you see it here, okay, is located usually at the level of T12 or sometimes at the disc of T12L1. Okay? And it's very short, 1.2 centimeters. Once it arises from the anterior aspect of the aorta, you can see here the aortic hiatus. Okay? This is the diaphragm, where the aorta becomes here abdominal. Once it's there, it will give this artery, the celiac. Okay? Now the celiac will divide directly, okay, into 3 main branches. One to the right, towards the liver, which we would call it, one to the right, towards the liver, hepatic, okay, or common hepatic. The largest one, however, will go to the left, as you see, from behind the stomach and behind the lesser sac, because aorta is retroperitoneal. Okay? This one will go all the way into the spleen. So which one will be this? The left? The splenic. This is the largest branch from the celiac. Okay? So to the left we will have the splenic artery. To the right we will have, which we call it common hepatic. Okay? And a small branch will come from the superior aspect. It will go up, then it turns loop. Okay? It will loop and go down along the lesser curvature of the stomach. This will become the left gastric artery. Okay? So now, before we continue, I want you to remember, celiac, 3 branches. Left splenic, right hepatic, superior, left gastric. When we speak about blood supply to the stomach, okay, let's put this aside and speak about blood supply to the stomach. Blood supply to the stomach usually comes from 5 sources. Okay? Along the lesser curvature, there will be 2 arteries passing there, and as you see, as they pass on the lesser curvature, they will give their smaller arches, okay, or branches to the surface of the stomach, anterior and posterior surface. Those 2 on the lesser curvature, one on the left side and one on the right side. We would call them left and right gastric arteries. Okay, and they unite together at the level of insularis and suture. So you will see them here as one here. Okay, one arch. So at the lesser curvature, we would call them gastric arteries. On the left, on the right, right. On the greater curvature, to distinguish them, we give them a longer name. Okay? Gastroepiploid or gastro-omental. So you will have another 2 at the greater curvature here. Okay? You will have the left gastro-omental and the right gastro-omental or epiploid. Okay? So when you hear gastro-epiploid, you know that artery is on the greater curvature. Gastric on the lesser curvature. So now we have 4 arteries. 2 gastrics on the lesser curvature, 2 gastroepiploids on the greater curvature. Okay? And the last arteries, 4 to 6 branches, goes to the fundus of the stomach. We call them short gastric arteries. Okay? The short gastric arteries. Okay? Okay. So we have 5 sources of blood supply to the stomach. The first one, the left gastric. Let's go with the gastric. The left gastric comes directly from the celiac trunk. Now the right gastric, the other one, as you see, as common hepatic is passing to the right, it will give the right gastric. So the left from celiac, directly, it will loop to go down. The right from common hepatic. Okay? The left gastroepiploid, as you see, the splenic, before it gets into the spleen, it will give down the left gastroepiploid. And superiorly, it will give those small branches to the fundus. So now, the short gastric or the fundal branches from the splenic. The left gastric from where? Celiac. The right gastric from where? Common hepatic. The left gastric from splenic. The splenic gives 2 to the stomach. Okay? Okay, the short and the left one. The last one is the right here, gastroepiploid. If you look carefully, the common hepatic, as it passes to the right, will give a very large artery that descends behind the first part of the duodenum. Okay, so it's also retroperitoneal. Once it descends behind the first part of the duodenum, okay, it will, below the duodenum now, it will divide into two arteries. One will continue on the curvature or in the concavity of the duodenum. Okay, what's there here in the concavity? Actually, it's the head of the pancreas. So as it passes, it will give branches to the left, to the head of the pancreas, branches to the right, to the duodenum. Okay, so this will be called pancreatico-duodenal artery. Okay, superior pancreatico-duodenal artery, and the other one will go into the right side of the greater curvature of the stomach, will be gastroepiploid artery. Okay, the gastroepiploid. Okay, right one. So this artery now will give two branches, one to the duodenum, the other to the pylorus, okay, of the stomach. So what we would call this artery? They agreed to call it gastroduodenal. It's a branch from where? From the common hepatic. Now for descriptive term only, once the common hepatic gives the gastroduodenal, now it will become, which we call it, hepatic proper. The hepatic proper or proper hepatic artery is the one which will get into the peritoneum now, into the hepatoduodenal ligament, into the portal triad. Okay, if you remember, we said we have portal triad, and within the portal triad, it will travel into the liver, okay, where it will be divided into left and right hepatic arteries. Okay? So, if we speak about the splenic artery, I told you what's about it. It's the largest branch of celiac trunk. We agreed with that. Okay? It passes posterior to the stomach. Okay? And above the body of the pancreas. So, if you look to this view, this is the stomach. You see the artery behind it and behind the lesser sac. If I remove the stomach here, you can see the shadow of the stomach down, and we remove the lesser sac peritoneum. We go retroperitoneally. You can see the pancreas here, and above it you see this is celiac trunk. The splenic is traveling behind the stomach, behind the lesser sac also. Okay, all the way above what? Above the pancreas. So as it passes, it will give branches to the body of the pancreas actually. So the splenic also provides blood supply to what? The pancreas. It supplies blood supply to the stomach, as I told you, by short gastric and left gastroepiploid. And lastly, it will provide blood supply to the spleen. Now, very important thing to speak about this artery. As you see that, I told you it's retroperitoneal, behind the lesser sac. However, the spleen is, what about this? It's intra or retro? Intra. So how does the artery reach into the spleen?
Splenic ligament.
So, in order to reach, it will go, as you see in this cross-section. Now, actually, this is the abdominal aorta, okay? As you see, this is the lesser sac of peritoneum, this is the stomach, okay? And this is the spleen. Aorta here will give here the celiac, okay? Celiac will give the splenic to the left. It will go all the way traveling here, behind this parietal peritoneum. So it will travel in this space, okay? As it's traveling in this space, below it, okay, or above it, below it, there will be the pancreas, below it, okay? But as the artery travels here retroperitoneally until this area, where it will get through this ligament to the hilum of the spleen. So now the artery will become intraperitoneal. You see there is peritoneal fluid behind it. What did we call this ligament previously? Splenico-renal ligament. Okay? So we said the spleen is attached to two peritoneal ligaments. One to the stomach, which we call it gastrosplenic. It's part of greater omentum, if you still remember. And the other one is splenico-renal ligament. Okay? So that's how the splenic become intraperitoneal. So it will enter what? Which ligament? Splenico-renal, to reach the hilum of the spleen. Okay? Now what does it supply? It will give branches to the pancreatic body, as I told you. It will give the short gastrics, I told you about them, and it will give left gastroepiploid. Okay? This is for the spleen. What about the hepatic? Hepatic artery is the right branch, yes? We say it's the right branch of the celiac trunk. It will pass in the right side, okay, to enter what? The hilum of the liver, okay, and it will be considered part of the triad, okay. Now, once we consider it part of the triad, which branch is it part of the triad? It's not the common hepatic itself, it's the hepatic proper. It's getting into the peritoneum, it enters the peritoneum after it gives the gastroduodenal, okay. Branches of hepatic artery, as you see, the first one is right gastric artery. Okay? Right gastric artery. Where does it go?
Curvature.
On the lesser curvature of the stomach. Yes. It anastomoses with which artery? As you see, with the left gastric. Okay? Is this clear? Okay. The sixth one is gastroduodenal. I told you about. Why they call it gastroduodenal again? Because it will provide blood supply to the stomach and to the duodenum. Gastroduodenum descends behind the duodenum, so it's retroperitoneal, because duodenum itself is retroperitoneal. It will give the right, what's this?
Right.
And this one, superior pancreaticoduodenum. They call it superior because it only supplies the upper half, the head of the pancreas, and the upper half of the duodenum. There is another artery come to supply the lower parts. Okay, we call it inferior pancreaticoduodenum, and we will speak about it. Okay, just a minute. Then the artery will become hepatic proper, as I told you. The hepatic proper will terminate into left and right hepatic arteries. There is a very important branch coming from the right hepatic. I told you about it. It's important for you in clinics.
Cystic artery.
From the right branch, there will be a small artery go to supply the gallbladder. We call it cystic artery. This is very important, okay, because when you do cholecystectomy, you need to ligate this arm. Okay, so the cystic artery is a branch from where? From the right hepatic. Okay? Cystic artery comes from the right hepatic. So a quick review again for celiac trunk. You told me guys. How many branches from the celiac trunk? 3. What are these? The largest?
Splenic.
Splenic to the left. Okay? The second one in size? Common hepatic.
Common
to the right. And the smallest one? Superior. Okay? The left gastric superior. Okay. Now, from the splenic, which branches you will have?
Left.
Short gastric to the fundus and
Left.
gastric. Okay. Now, common hepatic will give also 2. One of them will be right gastric. The second one? Gastroduodenal. The gastroduodenal below the duodenum will be divided into superior, pancreaticoduodenal, and right gastric. The superior mesenteric now. Okay? Where is مين يسألني عن mesenteric؟ ما جاء في الجواب. عمر. What does mesenteric mean?
دورنا عليها طلع معناها ممبرين غلاف.
Mesointron. Mesenteric from 2 Greek words, mesointron. Mesos means in the middle. Intron, intestine. The intestine in the middle. So those arteries supply the structure of the intestines in the middle of the abdomen. Okay? That's what does mesenteric mean. Mesointron, intestine in the middle. Superior and inferior. The superior mesenteric artery. Now, before speaking about this, it's very important to have a little background about the embryology, okay, of the gut or of the GI tract. When the GI tract forms, it forms from 3 sources. Okay, we have the primordial gut. We have something called the foregut, which is the upper part, which extends from up all the way from the mouth until the middle half of the duodenum, until the major duodenal papilla. Where's the ambulatory orbit? Until there. That's the border. So almost, approximately half of that duodenum. Okay? So that's all above will be the foregut. So the foregut will include abdominal esophagus, stomach, liver, gallbladder, okay, pancreas, and upper half of the duodenum. So the accessory organs there, along with it, okay, with the foregut. The main artery to the foregut that will develop with it is the celiac. Now the midgut, so we have 3, foregut, midgut in the middle, and we have hindgut, the lowest one. hind means tail, the lowest one. Okay? In the mid-gut, it will extend from the lower half of duodenum, jejunum, ileum. What's after the ileum? Cecum and appendix, ascending colon, and then 2/3 of the transverse colon. All of this will be called the mid-gut. The main artery to the mid-gut is the superior mesenteric. Okay? Now after that we have the lower gut or the hind gut, which is the distal third of transverse colon. Then we have descending colon, sigmoid, rectum, to 2/3 of the anal canal. Because I told you, 2/3 up from endoderm. 1/3 comes from outside, ectoderm. So 2/3 of the anal canal. All of this is the hind gut. The main artery developed along with these structures to supply it is the inferior mesenteric artery, which we later will call it inferior mesenteric. Okay? So if you know these two border lines between the three parts of the gut, which is half of duodenum between foregut and midgut, okay, and 2/3 of the transverse colon and distal third, the last third of transverse colon, between midgut and hindgut, you would know which part, which artery supply. Because foregut is the celiac, midgut, superior mesenteric, hindgut, inferior mesenteric. So if I told you, what about the lower half of duodenum, directly it is the superior mesenteric. Jejunum, superior mesenteric. Ileum, cecum and appendix, superior mesenteric. Ascending colon, superior mesenteric. 2/3 of transverse colon, superior mesenteric. Now, here the midgut ends. What would start with the distal third? The hindgut. So distal third by inferior mesenteric. And all the way down until anal canal. Okay? So what's the most important thing to distinguish is the border between foregut, midgut, hindgut. Half of duodenum, 2/3, 1/3 of transverse colon. Okay? Clear? So if you're going to speak about superior mesenteric now, where does this artery? It usually arises a little bit below, at the level of L1, below the celiac trunk. A little bit below the celiac trunk, at the level of L1. This is celiac, you see it here. This one below it is the superior mesenteric. Okay? Below the celiac trunk, just above the left renal vein. This is clinically important now. You see that this artery is passing anterior to the left renal vein. So any problem here, the artery can compress what? The left renal vein. Okay? Interfering with venous drainage from the left kidney. Okay? So this is very important to notice in this relation. It is going anterior to the left renal vein. It will descend then behind the neck of the pancreas. If you look carefully here, the artery will go behind the neck of the pancreas. Then, at the lower part of the pancreas, it will go anterior, okay, to what? To the third part of the duodenum. So هو بيطلع من الخلف. بيمشي ورا البنكرياس، تحت البنكرياس، below the pancreas، بيطلع للأمام وبيروح أمام الديودينم. Okay؟ لأنه هون بيبدأ دور. Okay? Here its role will start because once it's emerged, it will give an artery, as you see here. Once it emerged, it will give artery to the concavity here of the duodenum. هذا الارتري بده يمشي في الكونكافيتي ويغطي اللور half of the body واللور half of the duodenum. اللي هو شو بسميه؟ inferior pancreatic duodenum. Okay? This is the inferior pancreatic duodenum. So if you remember حكينا في واحد superior pancreatic duodenum. وين بيجي؟ هاي الكومن هيباتيك بيعطي gastric duodenum وهون بيعطي superior pancreatic. So here is the inferior pancreatic duodenum. So the relations of superior mesenteric is very important to know that. هون أول شيء anterior and above the left renal vein. High important clinically. Behind the neck of the pancreas. Anterior to the third part of what? Duodenum. It supplies what? It supplies the intestine from lower half of duodenum the way the 2/3 of what? Transverse colon. اللي هي شو بسميها embryologically? The midgut. So what about its branches? We're going to speak about its branches. Let's remember how many structures there in the midgut. We have lower half of duodenum. Yes? What else we have? Jejunum. Ileum 3. Cecum appendix 4. Ascending colon 5. To left transverse colon 6. فبدي 6 branches من السوبيريور mesenteric. Okay? So I need 6 branches from it to these 6 structures. For the lower half of duodenum, the first branch I told you about, which is inferior pancreatic duodenum. For the jejunum, it will give several branches, بسميهم jejunal arteries. Okay? So you will see several branches go to the left side because the jejunum more in the left side. We will call them jejunal branches. What's after jejunum? Ilium in the lower part. So in the lower part to the left also you will have several ilian branches. So I have 3 several branches. Inferior pancreatic duodenal, jejunal, ilial, شو بعدين في? Cecum and appendix. So when you look to the cecum and appendix, this is here, we look to the large intestine, this is jejunum, this is ilium, okay? And this is how you see the superior mesenteric. طلع من وراء البنكرياس والآن anterior to the third part of duodenum, okay? هون بيجي الليجامنت فيترايتس وبيبدا الجيجينم. فأول برانش راح يعطيه this one شايفينه؟ للديودينم، inferior pancreatic duodenal حكينا. بعدين بيمشوا بيعطي هذول البرانشز لوين؟ to the jejunum. Then those branches to the ilium. Now for cecum and appendix, it will give what? It will give this artery. You see it? This artery we would call it iliocolic. Why iliocolic? Because it will supply the terminal part of the ilium also. Okay? And the cecum, the first part of the colon. So it's for small and large intestine. Iliocolic. Okay? This iliocolic artery is very important because once iliocolic descends down into the right lower corner of your abdomen, okay, as you see here, it will suddenly divide into 4 branches. Ascending branch, descending branch, anterior, and another one posterior. You cannot see it, okay? فبيصل الإليوكوليك في الرايت كورنر وبعد الخسك the 4 arteries. The other one, the ascending aside, or the superior, let's say, if it's easier, this one will reflect to supply the proximal part of ascending colon. فبيسموه colic branch أو superior colic branch of الإليوكوليك. الثاني شايفين بيعمل يوتيرن وبيرجع مشان يغذي ايش؟ الإيليام. The inferior iliac branch بتسميه. اوكي؟ مش ما يسوقه. The inferior iliac as it returns back on itself, it loops back, it will go and anastomose with what? With the superior mesenteric itself. The superior mesenteric بينتهي بأوبن end مع البرانش تبعه نفسه الإليوكوليك. اوكي؟ اللي هو الانفيرير branch of الإليوكوليك. So you see the artery going as one structure. Okay? So Iliocolic will give a superior colic, will give inferior iliac, which anastomose with the superior mesenteric itself. Then it will give 2, one to the anterior surface of the cecum, بسميه anterior cecum, okay? And the other one to where? This is the anterior cecum. The other one will go behind, okay? This one here, it will go behind the cecum, posterior cecum, okay? Behind. The posterior cecum now, because appendix, as I told you, most of the time is retrocecal. What does retrocecal mean? Behind the cecum. But it's not retroperitoneal. It's intraperitoneal. It has its own mesentery or mesoappendix. And you saw it during the surgery, okay? In the video. So appendix is retrocecal intraperitoneal. Remember this if you ask about it. Retrocecal intraperitoneal. It's behind the cecum but inside the peritoneum. Okay? Since it's retrocecal, the posterior cecum will give a branch to the appendix. We call it appendicular artery. So iliocolic will give 3. Superior colic, inferior iliac. Anterior cecum, posterior cecum. From the posterior cecum, you will have a branch to the appendix. Okay? Back again. Lower half of duodenum عندنا inferior شو سميناه؟ pancreatic duodenum. شو بعديه؟ الجيجينال. Jejunal arteries, ilium, ilial arteries, هاي 3. Cecum appendix, iliocolic, ilium and colon. Iliocolic, هاي 4, ضل 2. واحد بغذي الباقي الاسcending colon، شايفينه؟ بيروح الاسcending colon in the right or in the left side? Right side. So we call this artery right colic. Okay? Because it goes to the right. The right colic artery, okay, which goes to supply what? All the, لما يصل شايفين بيعطي descending branch و ascending branch to continue all over the ascending colon. The last one, this one you see, أول ما بيطلع بدخل في الميزنتري وبيمشي بالأمام مباشرة. شو في أمامه بيكون؟ Transverse colon. It goes and divides into proximal third و middle third of transverse colon. Since it goes in the middle directly all the way until they call it middle colic. Middle colic شو بيغذي؟ Proximal 2/3 of transverse colon. So now what are jejunal. Jejunal branches, iliac branches, cecum appendix, ileocolic, ascending colon on the right side, right colic, with transverse colon proximal to thirds. The middle colic. سليبر كوديسنتريك كولون شو بصير الارتري بيروح له؟ ده ليفت كوليك اللي هو من وين بيجي؟ Inferior. So for the inferior pancreatic duodenum now, we have what? We have the remaining behind that, اللي هي distal third transverse colon and descending colon. So the artery will be left colic. بعد الديسندنج كولون شو في؟ حرف الاس shaped colon. The sigmoid, okay? Sigmoidal arteries, 2 to 3 in number. And then the last thing to the rectum, superior rectal artery. Superior rectal is the termination of inferior mesenteric. Once the inferior mesenteric here cross over the left common iliac, it will become by default the superior rectal artery, which will supply the rectum and the upper 2/3 of anal canal. Okay? So now it's up to you to fulfill in space, guys. Here, the middle colic. You see this artery here? Okay? This is the superior mesenteric, and this artery will pass here to the transverse colon. It will pass in the transverse mesocolon. So runs forward in transverse mesocolon to reach the transverse colon. Okay? Fill this. Superior mesenteric branches. Lower half duodenum.
Jejunal.
Inferior duodenum. بغادي الجيجينم
Jejunal. Ilium.
بغادي الإليوكوليك. Remember, this is very important after. Okay? بعدين الأسندنج كولون.
Right.
Proximal 2/3.
Middle.
That's it. After the inferior mesenteric, this is the inferior mesenteric, you see? After it crosses, this is the left common iliac, this is the right mid. After here, it crosses the left common iliac, it becomes بعد ما الانفيريور mesenteric يقطع الليفت كومن iliac artery هون. شايفينه؟ الآن هون شو صار اسمه هاي؟ Superior rectal artery, the terminal branch of inferior mesenteric. What does superior rectal supply? لو سألتكم الامتحان. Rectum, upper 2/3 anal canal. Okay. What does left colic supply?
Descend.
Left colic artery شو بدها؟ Descending colon كمان شغلة.
1/3.
Distal third transverse colon. Okay. The distal third transverse colon. Okay. Where does a reticular artery arising from? Directly. كلمة directly مهمة. لأنه indirectly from where? From the superior mesenteric. Okay. So directly from the posterior cecum. Okay. Remember this. There is direct branches or indirect branches. Okay. Which artery is responsible for supplying the upper half of the duodenum? Celiac, yes, or superior pancreatic duodenum directly. Indirectly the celiac. Last thing to speak about is the abdominal aortic aneurysm. Okay? Aneurysm means dilation. The artery becomes very wide, okay? Because of weakness in its wall. So it's a localized dilatation. You see? The aneurysm is a localized dilatation, ballooning, as you see, like the balloon, okay? Of abdominal aorta that exceeds the normal diameter by more than 50%. أكثر من نص, okay? So the diameter is 1.5 times than the normal one. Okay? Mostly in the abdominal region. The aneurysm is infrarenal. Okay? Below the level of the renal vein, arteries. Okay? Below the level of the renal arteries. In old people mostly with more than 65 years of age, because of what? Because of degeneration of tonica.
تونيكا اكسترنال.
ليش الدايلاتيشن بصير؟ الوول ضعف. شو اللي بيعطي الوول قوة؟ سترينث في الارتري. تونيكا ماسكولار اللي هو تونيكا ميديا. Because of degradation in tonica media and reduced amount of elastin protein. الالاستيسيتي تاع الارتري قلت. اوكي؟ فبيبدا يضعف الوول وبصير في ايش؟ دايلاتيشن. اوكي؟ The risk factors, several you can read them. It's usually asymptomatic, except major complication is, this is what we concern in the aneurysm. So when you have abdominal aortic aneurysm, the most clinical problem is the rupture. With time, it will lead to what? To rupture, which we call it rupture of triple A, or triple A rupture. Okay? Triple A means abdominal aortic aneurysm. This is a life-threatening condition, okay? Where large amounts of blood can go where? Now, into the abdominal cavity, okay? Not into the peritoneal cavity. Why? لأن الأورطة retroperitoneal. So it will go into the abdominal cavity where blood spills there, okay? Death within a few minutes. Mortality rate حتى 90% للآن. Mortality rate 90%. Aortic aneurysm mortality rate 90%. As you see here, this is a view. You can see the IVC on the right, and here is the abdominal aorta. You see how large it is, and there is dilatation even extended into the two common areas. Okay. Let me show you now. This is small. Last thing, guys.
Your surgeon will perform an abdominal aneurysm to prevent the rupture of a bulging area of your aorta. The largest artery in the body is the aorta, which is attached to the heart and receives blood directly from the left ventricle, or main pumping chain. The aorta is divided into four parts: the ascending aorta, aortic arch, thoracic aorta, and the abdominal aorta. The abdominal aorta is the last and largest section of the aorta. It supplies blood to the lower regions of your body, including the organs in the abdomen and pelvis. The abdominal aorta ends around navel level, where it splits into the two iliac arteries that carry blood to the legs. The aorta has a thick wall, so it can withstand the high pressure of blood being pumped from the heart. Over time, the wall of the aorta may weaken, slowly bulging outward like a balloon. When this condition occurs in the abdominal region, it is called an abdominal aortic aneurysm. The surgeon will perform an open abdominal aortic aneurysm repair when the diameter of your aorta exceeds 2 inches, or if...
So now to repair it, you need a vascular surgery. Okay? There are two types of repair. There is an open surgery repair and endoscopic or endovascular, okay, surgery repair, where the endoscope will get through major blood vessel, okay, reaching into the abdominal aorta, to the area of the aneurysm, okay. So endovascular or open, you have an incision in the abdomen. What kind of incision in this case usually they will have? Median, complete median incision, okay.
If you're having symptoms such as intense abdominal pain, or an abnormally prominent abdomen.
It exceeds 2 inches, which is 5 centimeters.
An IV line will be started to provide you with fluids, antibiotics, and anesthesia. A traditional open surgical repair is performed under general anesthesia, which means you will be asleep for the duration of the procedure.
General anesthesia, what's directly? You see after? Breathing tube. Why the breathing tube? Okay, to maintain our airways and inhibit the collapse by genuines.
And into your windpipe to help you breathe during the operation. When you are asleep, a catheter will be inserted into your bladder to drain your urine and monitor your kidney function. Your surgeon will begin by making an incision from the breastbone to below.
Which incision is this?
Locate the aneurysm.
Which forceps is this? Hemostatic forceps. Which forceps is used? Cohar's forceps.
Will then open the aneurysm and sew an artificial graft.
So artificial graft. This is an artificial graft. This is made usually from dacron. It's a polyester material, okay? Which is called thermoplastic polymer. Okay? Plastic harari. Okay?
Your surgeon will stitch the wall of the aneurysm closed over the newly placed graft. The graft will reinforce the walls of the aorta. Your your surgeon will close the abdominal incision with stitches. The total length of this procedure is usually 4 to 6 hours. Your surgeon will perform endovascular aneurysm.
Now the endovascular one, the other type.
If you have severe heart disease or are at increased surgical risk due to age or other medical conditions. Before the endovascular procedure, as with the open procedure, an IV line will be started to provide you with fluids and antibiotics. You may receive general anesthesia, or you may receive a sedative and an epidural or regional anesthesia to numb only the lower half of your body. Your surgeon will begin by making a small incision in your groin over your femoral artery. Then he or she will insert a guide wire into the artery and gently push it up toward the site of your aneurysm. A catheter or hollow tube will be passed over the guide wire and pushed toward your aneurysm. Using live X-ray pictures as a guide, your surgeon will pass an endovascular stent graft, a compressed fabric and metal tube, through the catheter to the aneurysm. Then he or she will open the graft, which will be held in place with metallic hooks and stents. Your surgeon may insert additional graft components to extend the graft into the blood vessels supplying your legs. Once the graft is in place, your blood will flow through it, not into the surrounding aneurysm sac, which will remove the pressure from your aneurysm. Finally, your surgeon will remove the catheters and close the incisions in your groin. The procedure will generally take 2 to 3 hours.
Okay, so let's look more closely to something more real. So now, in this case, as you see, 81 years old, male, okay, during its abdominal ultrasound showed subrenal abdominal aortic aneurysm exceeding 5 centimeters in diameter. Once the aneurysm is more, or the dilatation, let's say, more than 5 centimeters in diameter, it's an indication for what? For surgical repair or surgical intervention. So it was, because of time, let's go quickly. It was transported to the operation room, okay, for open surgical repair. You see the patient here is under general anesthesia. And starting around, you see here, it's very clear, you can see one of the signs of aortic aneurysm. The pulsation can be visible where in the anterior abdominal wall. Okay, so if you look carefully here, you can see the pulsation. Look carefully for the pulsation. Disinfecting infection of the area. Okay, so this is a disinfectant. Then a median surgical incision was made. Now he's cutting through what? Through the fascia. Okay? Cutting through the muscle. Then now he's cutting through, this is the peritoneum. You see, he's cutting the peritoneum. Cutting through the peritoneum, you can reveal the abdominal organs. This is the muscle. The fleshy red part is the muscle. Now he's removing abdominal organs, reflecting them to look where behind. This is the aorta. You see it? Now he's removing the parietal peritoneum, covering anterior surface of the aorta. All of this is a dilated or triple A, abdominal aortic aneurysm. Now he's ligating the branches. Remember, 3 lateral branches, suprarenal, renal, and gonadal. Okay? See how much the dilatation, how large it is. Okay? This is a lateral branch, ligated. This is Cochle's forceps, okay, used to ligate the artery, superior. These are 2 for the common iliacs. And now he's cutting, opening the artery. This is a suction, okay? It sucks the blood directly, okay? As he opens, he's doing the suction. He's opening the artery now. Look what he will find inside. Atherosclerotic, black, very large, thrombosis, okay, thrombus, okay, made of atherosclerotic sheath. Yes, this is a reaction.
لا مش فيه هاي ابدا.
Meaning falls away inside the heart. This is the prosthetic, okay, graft, which made of ducting. This is the duct. You see how elastic it is? He's showing its ends now where inside the heart, okay, to make sure that blood will pass through it instead of passing within the heart. Place the graft inside the artery. See how it's showing it, okay, the lumen of the artery. He's showing the end, okay, with the end of the arm, okay. I will just want to show you one thing, what he do. This is very important. You see, before showing the other end, he's what? He's inserting what? Some normal saline, okay? Irrigation. Why? To make sure there is no leakage on that end. It has been looked carefully, okay? This is very important. He takes the exact size where he wants to ligate, cleaning and irrigating again, and then showing the other end to the common areas, okay, or to the lower part. Stitching. Closing the two ends together, okay? Again, irrigating to see there is no leakage. Make sure there is two more again. There is more leakage, he will keep stitching, okay? There. To make sure there is no leakage. Now, after finishing, he's stitching the walls, okay, of the aorta around the tube or the prosthetic graft. Remove the forceps. Now, electroprotectants. This is the atherosclerotic plaque, that's thrombus, returning the gut, closing the abdominal wall, you see that stitching the peritoneum and transversal fascia. See? Now when you finish and you remove, I will tell you now how to make sure there is no leak. The mesenteric, this is the mesenteric. He was showing the mesenteric. The peritoneum returning the duct and these are the rectus abdominis parts, okay? Now, for the skin, this is the page now. Look here, he's not stitching, he's clipsing the skin, okay? He stitched the muscles, stitched the fascia, but he clips, okay? Look what happened.